Sorry, our preliminary tech check slightly ran over, so it is now 4 minutes past 9. We are starting. Probably give it a couple of minutes to boost numbers to allow people to log in. Then we will be able to begin. From checking the recording of the last one, the main issue is me saying between every other word. So my main mission today is to stop saying so much and be more fluent. So let's see how this works. So yeah, I will begin. So thank you everyone here for joining us for this deep dive into drugs and the issue of chemsex. So for this topic, I'm certainly not the expert, but luckily I've got two of those here. We've got David Stuart. We've also got Dr. Janey Sewell. I'll be introducing them both, letting them introduce themselves in a moment. So some brief background for those of you who were not here 2 weeks ago. So this started off with myself, Professor Joe Neal and Professor Chris Chandler, originally doing conferences on live. And we had a great one lined up for June the 11th, but then of course, great live physical events had already stopped happening by then. We had some really good speakers, so we wanted all of those talks to happen. But of course, they couldn't do in the format that was originally proposed. So we have now launched this series of webinars. This is the second, and we will hope to continue doing these even when we have used up all of the talks from the original proposed day on June 11th. So without further ado, actually no, there will be further ado. So a little bit of housekeeping. So it will hopefully be a fairly fluent conversation between Janey, David, myself, hopefully mainly Janey and David. But as well as that, we very, very much welcome your own input. So please do put your own questions into the chat. And ask anything you wish, and especially if it's relevant to whichever aspects of chemsex we are discussing at that moment. And then I will pass those questions on to the speakers. And then once we are kind of done running through the pre-planned points, then please add any other questions, about topics we didn't manage to get to. And then we'll get to those towards the end. So now, since that further ado is over, move on to David. So to begin, David, if you could introduce yourself. I believe part of the reason you're here is I believe you came up with the term chemsex. So you tell us a little bit about yourself, and then if you could perhaps introduce chemsex by first of all telling us what it is.
Sure. Hello. Hi, everybody. Yeah, my name is David. So at the moment I work as a drugs counsellor, but specifically in the chemsex world. And I'm not trained as a counsellor. Drugs workers are usually social workers more than sort of qualified therapists and things like that. And so I guess I'm a social worker. I work in London, but the way I got to be doing this work was I used to do a lot of drugs and chemsex myself. And as I was, it was about 20 years ago, and as I was, it was becoming problematic for me, and I was making changes and seeking help, I was continually being referred to sort of heroin addiction services. And that was complicated, and it wasn't helping me. It wasn't culturally competent around the things that I needed help with, which is particularly grinder, sex, gay sex, pleasure, and particularly the drugs, which are crystal methamphetamine, GHB, GBL, and methadone, methadone wasn't even around at the time, but they were all very new drugs, and they were too complicated, I think, for the the typical heroin drug services that were just ensconced in street homelessness and crime and that stereotype. So I started volunteering, and I became an activist and a campaigner, as well as sort of learning as I went along how to be a drugs worker. Just trying to get culturally competent chemsex support into the services where they're meant to be. And that I thought that required a whole reinvention of the word, a whole reinvention of the culture and of the support structures. So I wanted chemsex support to happen in places where gay sex was talked about easily and by matter of course, like sexual health clinics, like gay charities, places like that. And so that's me. I started campaigning and making those things happen and setting up the first chemsex support services in the world. I haven't really defined it yet because I just got coarse from that introduction. I'm embarrassed because I told you I do drugs.
Thank
you.
you.
Introduce Janey?
Yeah.
Thank you very much. David?
Hello, so I'm Janey. I am a sexual health and HIV specialist nurse, predominantly and preliminarily. And I have recently completed a PhD, which has been looking at chemsex and in HIV negative gay men. And I have met David in the course of his activism, because when he first started coming into Dean Street, I was a sexual health nurse there at a clinic in London, which is predominantly set up for gay men. And we were in a very interesting position where we were sort of on the cusp of seeing a lot of people, as David said, talking a lot about sexual behaviour to a lot of men who are actively seeking help or seeking care for sexually STIs and sexual health. And we were sort of in a conundrum where we weren't actually able or trained to talk about what it was that had been going on, which had led them to seeking this healthcare seeking behaviour. So I remember actually the first time we met David was in the waiting room, and you were saying, oh, I work for Antidote, and I was saying, oh, that's weird, because what are we doing here? And then that's where like the service kind of meshed together, and has been incredibly productive at being able to meet the needs of a blossoming public health problem that we have seen emerge in the last 2 decades, and bringing together drug services that are culturally appropriate and specifically meeting the needs of gay men within a sexual health service has been something that has then led me to do the research that I've done for the last 5 years, or just over 5 years, specifically looking at sexual health and the associations of sexual health behaviours with chemsex and outcomes related to that.
Great, thank you very, very much, Janey. And also thank you very much, David, for your very candid introduction. Wish I could be so candid if I wasn't sitting in a living room here in Singapore where such things are not encouraged. But yeah, David, I wonder if you could maybe fill us a little bit more in about the cultural history of chemsex. I think gave us great work on the definition there. So specifically, it's drug-enhanced sex between men, and it's very specifically said methamphetamine, GHB, GBL, and he said methadone, although that's more recently added to the repertoire. So I just wondered, so Janey mentioned this has been something in the last couple of decades. Have you been able to identify any sort of a starting point of when chemsex in its current form first became a thing?
Sure. Well, first of all, chemsex, sex, drugs, sex. So the broadest explanation of the term is just people having sex on drugs or alcohol, I guess. But the word chemsex has become culturally attributed to this, to a particular type of drug use epidemic. So you have to look at drug use epidemics in history to, I think, understand it. In the late in the early 1900s, there was a huge rush of people traveling from Asia to California for the Californian gold rush. And that Asian population were coming and bringing in a lot of opium. Opium had had a cultural and organic home within Asia for many, many centuries. But in this new environment, where Asian Americans had sold everything for this new life, they were in a culturally alien place. There was racism there that they hadn't encountered before, and a whole new world and whole new challenges. And so the way opium fitted into that population, it started to become more problematic than it might have been in an organic home, perhaps. And so we did see an opium epidemic begin in California in the early 1900s, and we saw the Chinese laundries that had sort of opium dens underneath them. And if we were going to try to get support for the Asian Americans at that time with the use of opium, we'd have to understand culturally what it's like to be a new Asian American in that part of the world in those circumstances. And of course, that wasn't the case. But I mean, that's one drug use epidemic that was uniquely and culturally definable. Another one might be, to stay in America, crack cocaine, and particularly the way it affected Black people in America. I want to say African Americans, but it was broader than that. Presidents were saying that crack was a black drug. The criminal justice system was disproportionately criminalizing and punishing Black people who were using crack cocaine compared to, for instance, white city boys who are doing powder cocaine, even though it's pretty much the same drug. So, I mean, again, if you wanted to understand the drug epidemic that we were talking about with crack cocaine in the 80s in America, you have to understand the history of racism. You have to understand racism from presidents' dialogue. You have to understand the injustices within the criminal justice system that is biased that way. And if you don't understand those things, you're not going to you're not going to provide very good healthcare. At the moment, we have what we're familiar with, which is the heroin epidemic, heroin, crack cocaine, alcoholism that's very much associated with street drugs, street crime, homelessness, poverty, and poor education, and sort of traumatic backgrounds, emotionally traumatic backgrounds. You don't do heroin to go out and have a laugh. It serves a very distinct purpose. And that's, we're pretty good at that. But, the services we have at the moment are pretty good. There's amazing outreach workers that really understand the cultural competency. They go out onto the street and they understand how that drug use epidemic works on the streets. And they work in a very culturally competent way with that population. And that's amazing. And so when Chemsex came along, okay, a new phenomenon, this was different. And we're trying to fit it into boxes like a heroin box when it's actually not that at all. So my challenge was to redefine it, rename it, and give it a home. And by doing that, it needed a clear definition. And I think understanding the culture of it started with, things were changing about 20 years ago. So methamphetamine, let's start with, well, HIV. We can't separate chemsex from HIV if we're talking about gay men and gay sex. It's a population that's disproportionately affected by that. And 20 years ago, there was no PrEP. The PrEP is a medicine that you can take that HIV negative people can take. And if you take that medicine, it pretty much guarantees that you will not catch the virus. You will stay HIV negative no matter what you do, pretty much. And then that wasn't around then. We've got things like PEP, which is PEP is a medicine, like a morning after series of medicines, which you can take when you have had an incident the night before or a couple of days before when you might have had sex with someone who might have been HIV and infectious. So you can take this medicine. So that wasn't around 20 years ago either. So 20 years ago, HIV was terribly frightening and it was changing gay men's relationship to gay sex. Gay sex suddenly became disgusting globally, culturally, around the world amongst heteronormative kind of people. Driven by AIDS fear media campaigns. But also there was authentic fear too. So gay men were also gay sex suddenly became less about pleasure and connection and love and all those things, became very much about danger, risk, death. Endemically, it was just impossible to separate those things. Health services had to drum into gay men this message: your sex is dangerous, it is deadly, it is risky. We want you to be aware of that and we want you to know those things. And that message really sank in, really internalized and ruined the experience of gay sex for a whole generation of gay men. And actually not just one generation, further generations it seemed to be. So I guess the beginning of, you have to understand that if drugs serve many purposes, but one of them is to medicate our behavior, then it's quite understandable. It doesn't need too much explanation, I think, that gay men might have needed a lot of medication to get themselves through the pleasure of gay sex through an AIDS epidemic. So that was kind of the first thing, and things were changing. So HIV became less frightening as new medicines were developed, but the internalized fear didn't go away. And of course, the societal disgust of gay sex didn't go away very quickly either. Now, another thing that was changing was drugs. So the drugs that had been typically used by gay men, like ecstasy, cocaine, and MDMA, they've been used in very large numbers by very large numbers of gay men for many, many decades, and without a lot of harm. So there was this huge, another drug use epidemic of ecstasy, cocaine, MDMA on dance floors in gay communities, a particularly drug use epidemic that nobody really cared about because it wasn't hurting anybody. We didn't have gay men rushing to accident and emergency services with overdoses from ecstasy. We didn't have gay men rushing to A&E departments acting violently because of the way that drugs made them feel. They were just dancing and hugging. And we didn't have gay men rushing to drug services saying, help me, I'm addicted to my MDMA, or give me needles to inject. It's just, there was very low harm associated with them. So a whole population of rather traumatized gay men adopted this normalized drugs are okay in our world and not harmful, and adopted them culturally and normalized them over a period of decades. But suddenly, those drugs were changing. And it was almost overnight, about 15, 20 years ago, when crystal methamphetamine appeared and mephedrone appeared and GHB appeared out of kind of nowhere. I mean, some of these drugs had existed for a long time, but they weren't culturally normalized within gay communities. And suddenly they pretty much replaced those drugs. And all data from all around the world shows that gay men, in a period of about 5 years, pretty much dumped all of their fun recreational drugs pretty much overnight in favor of these new drugs in very large numbers. And these new drugs are really, really much more complicated to manage. Crystal methamphetamine is a powerful drug. It's highly addictive, causes drug-induced psychosis very commonly when you miss a lot of sleep. We don't have a lot of deaths associated with it acutely, but the harm that happens in regards to mental health and degradation of life over a period of time is quite phenomenal. So it sneaks up on you, that one. GHB is killing a lot of people. It's killing about 2 people a month in London, and that's similar in other places around the world where it's popular from overdoses. And that's so easy to overdose on. But also there's other things like sexual assaults, and there's things like STIs and HIV, and there's a whole lot of harms associated with them. And so we've been grappling with how do we not damn these drugs or damn the people using them or put more fear messages into this already traumatized population, but how do we support them in a way that they can be well informed about the drugs and make well informed choices about how to incorporate them into their lives and why they're doing it, and just being very conscious of that. So there's 2 things. There was HIV and there was the new drugs. And the other thing that was happening about 10, 15 years ago was apps. I'm talking about Grindr, basically, and other apps like that, which completely made the nature of sex very different. It PR'd your sex life very quickly. So it went from me needing to have a calm, reflective understanding of my sexual and emotional needs and an ability to communicate them to someone else. And suddenly I needed to have an emotional and awareness of my understanding, but also had to communicate it to someone over an app using 24 characters or 120 characters and a photoshopped image of my abs and a PR version of it. And hookup culture was kind of born, and that's very immediate and didn't allow a lot of time for communication, for bonding. It required a whole lot of skills that, to an already traumatized population, required their sex life now needed an extra set of skills. It was just complicated. And so with all of these things going on, HIV, new apps, new drugs to a traumatized population, it just became it created a fertile ground for problematic drug use to develop and for drugs to be used to medicate those things rather than for just purely pleasure and recreational purposes. And so Chemsex, the culture, was born, and the services that we're going to be providing support Chemsex needed to understand all of those things.
And I think that's interesting, isn't it? Because I think that's where we found certainly that sexual health services were kind of lagging maybe behind in terms of what we could provide, because we were aware of the fallout of what was happening after a long weekend of chems use, or a big chemsex party and multiple people presenting from the same event for PEP or sexual health screening, and with a sort of slight inability to kind of know how to talk about it appropriately, or how to talk about what the drugs were, or really have a genuine understanding of what they do, or the kind of risk of coming down or coming off those drugs. And so I think in a way the sexual health services have been playing catch up with this culture, or this shifting culture of drug taking for some time. And it was really only when services became far more integrated, and they're not integrated in a lot of places around the UK, and it really is only in sort of large urban areas where like there's a big gay community that has a demand for this, and lots of sexual health services have been reaching out to you, David, and to Dean Street to kind of look at this blueprint of how to provide the services that their presenting clientele are requiring. And just the other thing I think is really interesting, David, that we've talked about before at the European Chemsex forums, is that the difference in culture around the drugs themselves. So in the UK, we really define chemsex as the use of crystal meth, GHB, GBL, or methadone for sex. But in other countries around Europe, methadone isn't on there. It would be more ketamine. And I think so there is a kind of our standardized definition of it in the UK is different to that in Europe. And you know, you might go to certainly, like I think Berlin, where the culture is like to use different drugs, but we've just absolutely seen crystal meth, GHB, and methadone become kind of the three main drugs of our chemsex phenomenon.
Yeah. That brings me on to something, sorry, which I was going to ask then. So firstly to say, I've noticed there's quite a lot of sign-ups from outside of the UK for this, which is absolutely great. So thank you very much to all of you, from both in and also outside the UK. But that's going to bring me to something I was going to ask as well, is how much is chemsex a British phenomenon? Is in the UK, is it particularly rooted in some places? Are there kind of chemsex capitals? I think Janey, you mentioned it might be, you know, chemsex services could be found in any large urban area with a large LGBT population, but are there, you know, is it concentrated in some areas? And is chemsex a recognised term outside of the UK as well?
Well, I think increasingly it is. There have been two quite large studies in the last 5 years, the European men who have sex with men's internet surveys, that have really shown that chemsex is widespread in Europe, and that there are kind of capital hotspots such as Berlin, such as Amsterdam, and it's not something that is just confined to the UK. And actually the sort of data from the early 2000s shows that it was just an undefined phenomenon that was predominantly happening in the US, this kind of use of crystal meth more specifically to enhance and facilitate sex. And like David said, that crystal meth is that use has then spilled over into the UK. But I think, David, you using your kind of knowledge of or your interaction with is it, I can't remember the name of the group in Amsterdam that are really
Mainline.
Yes, that's it.
So yeah, there's the data of a prevalence of chemsex around the world, which is, again, it's a really hard thing to achieve, actually. Things like internet surveys invite people to have a reflective, objective opinion of their own drug use and to put it online, and they have to be interested in doing it anyway. And I think that the nature of drug use quite often goes with denial sometimes, and it can go with an ambivalence or a reluctance to look at it consciously. And then people misunderstanding or having different interpretations or different definitions of the word chemsex and going forward. So there's a whole lot of chemsex data that have got nothing to do with the drugs we talked about, or even it might be just about white housewives who smoke marijuana and have sex, and that's chemsex. So there's a lot of very blurred data coming around. What I know from my travel is I've been everywhere, I think. There's a version of it everywhere. Wherever there is Grindr and a large gay population, there is hooking up and there is chems. And so it does manifest very differently around the world. A city, you mentioned Amsterdam, city like Amsterdam where there is a culture of sex education in schools from a very young age, a very LGBT inclusive and sex positive sex education from a very young age, which, you know, would parents in England would go, oh, how dare you? But it's quite phenomenal how successful it is at de-shaming sex. And then there's things that even just like sex work is de-shamed to a degree and culturally normalized and de-shamed. And then there's drugs that you can buy in shops like marijuana, so it's decriminalized in that way too. So where there's less shame and also a more of a secular base across the land, there's less shame around gay sex. So those ingredients make for a lot less shame associated with sex. So therefore a lot less need to medicate the gay sex. Where there is a huge religious base, because most religions don't really like gay sex very much and find it quite disgusting. So wherever there is a city which is predominantly got a very religious base, you'll find more problematic chemsex happening. So you can go to a place like Tel Aviv, where there is a very strong religious base, but also some strange other cultural things too. Like in Tel Aviv, the city, it's cool to be gay, kind of provided you have a husband. And so I think 70% of gay men in Tel Aviv have children, born of IVF most commonly. So the family unit, the gay family unit with children and a husband is kind of accepted in the religious culture. But if you're one of the gays that likes going to circuit parties, doesn't subscribe to getting married or wanting to have kids, and you're just known as like that's kind of a naughty gay, then there can be an awkward exclusion or disgust again. I think that can feed into problematic sex too. And sometimes the needing to fit into my cultural background, to fit in, can manifest as a need to do drugs to medicate your sex life too. So, and then there's other versions around that too. And then there's meth in pretty much all across the United States, which has been there for way longer than it's been here. And even though it wasn't called chemsex, PNP, party and play culture, or gay hookup culture, particularly amongst Black Americans, Black gay Americans, Black gay and trans Americans, crystal meth has had a devastating impact, not just on the cultures and the people and the deaths, but a Black gay man has 1 in 2 chance of becoming HIV positive in the United States. And there's poor access to healthcare and insurance, and it's getting worse. And so meth and chemsex can manifest in that environment awfully. And then there are some cities which are kind of cool talking about it as a community issue. And there are some cities where we don't like talking about that. We don't like that word. And all those kinds of things that international activists and international researchers have to sort of manage as kindly as we can.
Yeah, adding to that, so I noticed Janey mentioned there was one of you mentioned a European forum of chemsex. It seems that was an organised place to try and understand chemsex across Europe. Has there been a global, worldwide, or is it really just on your travels and through talking to like-minded others that you've managed to hear about chemsex scenes outside Europe as well? Is there a central global organising point for trying to conceptualise what it is, how it varies across the world?
Apart from sort of me behind my computer and on airplanes, no, there's a couple. There's a European Chemsex Forum, which is an excellent thing. There's also, there is a global network, which is more about, there's a global Chemsex network, which is more about supporting the workers. So it's like a clinical supervision group for staff members who are healthcare advisors, healthcare workers. And then there's an Asian network for Chemsex too, that's been going for about 2 or 3 years. Which includes Australia and just geographically, but there's no global one, and I think that there wouldn't be a global one for HIV either. They become very broad. My personal job, my activism is very much about, if I travel to a city, I forget where I've come from and I just get immersed in the culture, how it's manifesting there. and I relearn what Chemsex is for that city. And it starts with going straight to the gay charities, and then going straight to the gay communities and to the pride organisers, and then out to the clubs and the bars, and sort of rallying up. And it all starts with drag queens. You know, if you can get as many drag queens as involved in being community activists, again, then you've got a really good foothold to start dialogues within that city. So I'm more for, there are some big global things developing. My personal work is very localized.
Right, great, thank you very much. And this is a question, I guess, yeah, for both as well. So it's something I'm interested in. So you mentioned that you think a lot of the growth of chemsex is related to a shaming of gay sex following kind of HIV moral panic in the 1980s. So I wonder how to understand chemsex along this axis. One is kind of, you mentioned the kind of almost, I guess, escapism, or doing so because of, problems in how gay sex is conceived, but for the others it might be, understood as something particularly hedonistic. Do you think there's a way you can either both expand on kind of how we talked of it there as an almost escapism, and at the same time as perhaps, a particularly hedonistic activity?
Sure. Well, the best way to describe, there's as many reasons for doing drugs as there are fingerprints on the planet. And there are many manifestations of drug use, whether it's just non-problematic or problematic. And then there's the personal perceptions of it. My perception of my use might be, mine's non-problematic, but my mum might think it's like she can see the problems really obviously. So trying to quantify and qualify all of those things is really, really hard. I usually try to avoid it, but think of it your own network. Drinking's very normalized within our own friendship circles. And so it's as broad as that. You've probably got a friend that drinks too much and doesn't remember what they did the night before, and just apologizes too much when they're drunk because they're an unhappy drunk. And then there's the violent drunk, and then there's the happy drunk. And then there's the person who's in denial of their drinking. And then there's the person who drinks and doesn't care anymore. Then there's a person who has days off and goes out drinking with you but doesn't drink themselves. And everyone's opinion of, do you reckon Ben's alcohol use is problematic, and the discussions you all have when he's not around. So with chemsex, don't try to channel it all into all of these different, it's as broad as that. And a healthcare worker's job and a community's job is to try not to box it into things, and just sort of personally tailor it to whoever you're talking to right now.
Yeah,
because that's part of healthcare, because Janey has to work and develop services where you have to think differently. Yeah,
and I was going to say, kind of tagging on to that, I think from an anecdotal perspective, as a sexual health nurse in clinic, you do see the two very different groups of people who may be using chems just purely hedonistically. They've kind of got a handle on it, and when you're talking about awareness of like what they want from their sex lives and what they're doing with chems, they may well have a very kind of healthy relationship with chems, and that can continue. And then often you see other people who have probably less of a kind of a grasp on a healthy relationship with chems, and sometimes that does stem from escapism, or does stem from some kind of traumatic event that may have happened in the past, or an ongoing kind of shame of sexual behavior, or kind of issues with even coming out or being able to express themselves to family and friends and social circles. But it's, not all chemsex turns into problematic chemsex. There are plenty of people who have a very happy, healthy relationship with chems and use it in a hedonistic way, and are able to kind of manage their sexual health lives very healthily. And yet there are, it's interesting trying to, you can't really, and some of the research I did as part of my PhD was trying to look at predictors of HIV diagnoses among people using chems, and whether or not there were any kind of social attributes, or any kind of physical or like measures of coming out to friends and family, as to whether or not that predicted a more kind of problematic use of chems, culminating in an HIV diagnosis. And it is really hard to kind of find what it is that puts somebody on one pathway where they can stay happy and healthy with their relationship with chems, or kind of go further down a different pathway that means that they end up needing a lot more help and support than somebody else. And I think, David, we are well, certainly your service is very much geared up towards recognizing both those groups of people, or that whole spectrum of people. And it's useful that people who are coming to a sexual health service know that they don't have to necessarily change their behavior, their chemsex behavior, to get support with their sexual health, because that we're not asking them to specifically, stop doing something, or just stop doing this because it's bad for your behavior, but it's because it's bad for your health. It's more kind of like, well, if this works for you, and then you're able to actively take PrEP on a regular basis, then that's great, and we can those two can work together. But it's when things become more problematic, and you can see see the way something's going to pan out for an individual, that we ask to engage with them more on a regular basis to try and help them kind of recognize what it is that they're getting from chemsex, whether or not that is what they want, or whether or not they're in control of it.
Your research, actually, Janey, because my favorite chemsex research in the world is your stuff. Because Janey, you've spoken to, is it tens of thousands of gay men around sex lives?
It's not tens of thousands. Well, it's in the thousands, but it's not quite tens of thousands. But thanks, David. I mean, if someone's going to fund tens of thousands, then please fund me. But yeah, it's certainly in the thousands. We've looked at the Aura study, which is attitudes to and understanding risk of acquisition of HIV, was looking at 1,000 or so men who were reporting or engaged with sexual health clinics, and looking at their relationship with recreational drugs, but chemsex drugs specifically, and looking at sexual behaviors. And then we followed these men over a 3-year period of time and looked at their chemsex trajectory. And interestingly, the studies were mostly taking place, or the clinical sites that participated were in London and Brighton. So, quite a good mix in terms of, access to a large group of gay men and access to drugs. And I would have thought at the start of the study that we would have followed an increasing trajectory of people becoming or using chems, and having like there being a problematic outcome at the end, either a sexually transmitted infection or an HIV diagnosis. But what we actually saw was no real change in sexual behavior over the course of 3 years, but a decline in the use of chemsex, and a decline in chemsex, and a decline in the use of the 3 drugs associated with chemsex, and a decline in HIV incident diagnoses, and a relatively stable sort of diagnosis of STIs. So, and partly that could be explained by the fact that we were recruiting, or that the studies used sexual health services that have fantastic chemsex support services in place, like 56 Dean Street, and like the clinic in Brighton, the Claude Nicole Centre. But also it could be explained by this culture of chemsex being something that people either do for a bit part of the time in their lives, for a specific bit of time in their lives, and then maybe their circumstances change, and they either go into a relationship or go out of a relationship, or something changes in their life that means they are no longer using chems, or they go back to using chems. But overall, this decline in chemsex prevalence was a surprise, and quite a pleasant surprise, I suppose, because we didn't look at whether or not chemsex was problematic or not. We just looked at people reporting chemsex use, and this is probably resulting in a, you know, part of that is feeding into this decline in HIV diagnosis that we've seen in gay men in London specifically, and actually the decline across the UK.
That's interesting. So one thing I'd like to ask you about that finding, which you may or may not have an answer to, is, so do you think that is an effect of the particular cohort you were studying with, perhaps being, perhaps, they're at the peak of their chemsex careers? So I use careers in my study heroin use, so I use the term career. I don't know if it's appropriate here, but you could have got people who were, say, peaking in their chemsex lives, and then there was a trail off? Or do you think that reflected a change overall in UK chemsex culture, and it might have been a more generational effect, that it simply was a bigger thing in the UK at the beginning of your study?
It's interesting. I think in terms of in terms of a peaking, starting at a peak and then seeing a decline, there's been a recent study that's actually shown that chemsex prevalence between 2015 and 2020 hasn't changed, and it is roughly about this the same amount as what we've seen, or what we reported in the Aura study, which is around 30% of gay men who are using sexual health clinics are reporting chemsex. And I think in terms of like a chemsex career, and David, you could definitely talk more about this, because I've seen that brilliant YouTube clip you did about a chemsex trajectory and kind of how that takes off. We've definitely seen, and I think it's reported in other studies, specifically like this big European men's internet survey, that chemsex does actually kind of peak in the later age groups, in terms of like being 35, later age groups, like slightly older age groups of men, so 35 plus. And we had quite a good representation of young men, particularly in the longitudinal component of the study. So we wouldn't have expected that, and we might even have expected that as they got older and carried on participating in the study, that their chem use might have increased just as they have aged. So I think it is actually more a reflection. The decline is more of a reflection of the services that were in place at the clinics that we recruited from. And I think from David, maybe you'd just like to talk about the trajectory that you've seen. Is it sort of after 6 visits you see either an increase or a drop off of chem use?
No, so in a course of most drugs work pretty much actually around the world, is the basic models are someone will engage in 6 weeks of drug use support, and the most effective support are ones where in regard to chemsex, when gay sex is talked about very easily, like how to manage grinder, what does it feel like, what is good sex, what is bad sex, what would you like good gay sex to be? When those questions happen, the outcomes for a person's goal around chemsex is much better, which is why I like Janey's research so much, because it really kind of, my interpretation of it was Janey was having conversations with gay men in an area where they're normally just asked clinically about what infections they've had and what caused it. But Janey was having more complex conversations around their gay sex lives. And that same research showed the people who were having those conversations were seeing a decline in their chemsex use. So there's that. And the other trajectory that we kind of, if I sum up all of my experiences from around the world talking to people, and I do see about between 30 and 100 people a week sometimes online, or have conversations around this. So there tends to be, in year one, it's about 6 years, not 6 sessions. So in year one, chemsex is kind of fun. The drugs are fun. You feel, wow, this feels amazing. All my inhibitions are gone and I can fit in and I like my body and I don't hate my body and I'm more confident to pick people up and I can deal with this complicated grinder rejection game better when I'm on drugs. Wow. Yeah, first year is like amazing. A few hiccups maybe. Year two it's accelerating a bit. It's not just on bank holidays now, or it's now sort of creeping up into maybe once a month or more. A few, maybe 1 or 2 G overdoses once in a while. Whoops. Year three, it's like missing a day or two at work. or college. And the thing you look forward to most when you have a weekend off is doing that. And you might prioritize it over sort of friendly barbecues or seeing your mum. And then in year 5 and 6, it's accelerating. Might have been opportunistically introduced to injecting. That might become more of a thing. There's more longer benders, 3-day benders, missing more days at work, and it becoming more like what the stereotype of addiction might look like. And in year 6, it's a lot of psychosis, a lot of repeated psychotic episodes, weekend after weekend. And a lot of degradation of mental health and harm. And it seems to them like the only way to cope with this drama and the mental health and the depression caused by these drugs is to do more drugs. And then they're in that cycle. So whereas something like ecstasy, the trajectory towards using drugs and developing harm is almost like 0. You could watch someone doing ecstasy in January of the year 2000. And if they were doing 2 ecstasies every Saturday for the 20 years, you wouldn't see much difference in their behavior or presentation 20 years later. If someone's doing heroin in January, they're probably going to need help by October. That's just because of the nature of the drug, the type of person that's attracted to it, the boxes it ticks, and the nature of the drugs and its effect on the body. And with Chemsex, generally, there's like a 6-year trajectory. And so it can be quite difficult to explain year 6 to someone who's in year 1 or 2. But again, it's not true for everybody. There are some people who really work at how do I incorporate this risky thing into my life in a way that it is just about pleasure and enhancement, and I have boundaries so it doesn't become problematic. And when someone sits down with a drugs worker, a professional, to establish those boundaries and keep themselves on track and maintain discipline around those boundaries, they can actually manage to use for a much longer time than 6 years before it might not even become problematic.
And I think that's again, because the sort of follow-up component of the study that we did was only 3 years long. But just like David said, this repeated engagement, A, with sexual health services, but B, with this kind of reflective behavior in terms of reporting what it is that you have been, the individual participants were using in terms of chems and their chemsex life. May have caused people to kind of actively reflect on that, which would then have meant that they either consciously stopped some of their chemsex use, or yeah, I mean, it could have worked either way, I guess. But it's hard to know whether or not this is a true reflection in it was a true decline. Certainly because it's some of the first data to actually look at a chemsex trajectory in a large cohort of gay men. But yeah, it's from a sexual health nurse perspective and being in clinic, it's fascinating that there are these like quite clear pathways in terms of seeing somebody who initially has a healthy relationship with chems, and then when that veers off into an unhealthy relationship, and you're seeing them either more regularly or not at all, and that's, I think, when you worry a lot more.
Great, thank you. Actually, that was a couple of things you said there pricked my ears up a bit. So David had mentioned that there's some injecting of methamphetamine within the scene, and something that brought my mind onto is, so one of my previous occupations, I used to volunteer as a harm reduction worker, primarily working out of a needle exchange at a great place called Inroads in Cardiff. So of course, partly what we were there for was to help prevent transmissions of certain bloodborne viruses by giving out lots of clean injecting equipment. Certainly providing advice on, since chemsex would have been part of our repertoire, although in my time there, I don't think anyone did ever present asking that. We did have condoms there to give away that was primarily aimed at sex workers who came in, although they would be given to anyone who asked for them. So I'm wondering, when working as a sexual health nurse, specifically as a kind of chemsex expert, did you have clean injecting equipment to give away? Was that something you would advise on? And did you have a close relationship with harm reduction facilities from the drugs world in your line of work?
Well, I mean, yeah, so it's interesting that actually you've asked basically how David's service has kind of come into the sexual health clinic. So there are, certainly there are different kind of packs that we can give away for people who are presenting and needing clean needles. And they are accessible, hopefully, from most sexual health services. But part of the problem is actually getting or training people to have that open conversation with people, with the men coming in through the door, and feeling comfortable enough to ask, you know, about injecting and whether or not they would like clean needles. So 10 years ago or 15 years ago, I would have said absolutely not. There was no kind of meetup between sexual health services and drug services, and that has really been turned on its head in the last I can't even remember. I feel like pre-children. I don't know how long ago it was. Was it 2012, David, that we were? Was it 2012 that you came into Dean Street? That the services started operating from Dean Street?
2010.
2010. Okay, there we go. I've just erased 2 years of my life. But yeah, so that was like the turning point, I think, and really the first clinic in the UK and in I might say Europe, maybe, to actually have an integrated sexual health service with Chemsex, but at the time it was harm reduction services. And it was really, you know, amazing to be able to have that support, because, you know, as you are probably aware, when you are within the NHS massive kind of corporation and you're providing a service, it's often very difficult to kind of to look outside of your immediate caseload and issue of what's going on. So if you're trained to be providing sexual health care and HIV care, you know, you have very limited time to actually like try and work out how to reach out to another support service that isn't necessarily provided by the NHS. And that's where kind of we were incredibly lucky to get that service set up in terms of the integrated drug use and provide that Chemsex support through the sexual health services, which I think is really key to a successful service.
It is key. It's so James, you know from working in the drug service that the bulk work in traditional drug services is very behavioural mostly, and then there's a smaller clinical element that it might be an addiction psychiatrist and a prescribing nurse for the hardcore end of the clinical responses to addiction. But the bulk of it is behavioural support workers and outreach workers that really understand culture and behaviour. So in sexual health clinics, traditionally, there's been a kind of good relationship. Again, they're very separate as models, the clinical care and the behavioural support. They're kind of very different. And what's happened in sexual health clinics since the HIV epidemic is a kind of divorce happened where there was the clinical support, like testing for STIs, testing for HIV, and HIV management and care and prevention was all managed sort of in a clinical setting, like a sexual health clinic. And then when there was something behavioural, like why does he keep catching so much gonorrhea? They send them to the charity to deal with the behavioural. Why is he having this kind of sex that's leading to these kinds of problem stuff? And that's two different buildings on two different sides of a city, and asking a person to engage in both, when to the patient or the client, it feels like these things are very integrated. What I think Chemsex has done is kind of forced the sexual health centres to merge the behaviour and the clinical together, because Chemsex is absolutely an HIV issue. It's less so as we get better prevention technologies. Like in England, we're lucky we've got some, but there's many cities in the world that don't have easy access to PrEP or PrEP, and lots of stigma to accessing services. So having being able to address the behaviour and the clinical elements of Chemsex all in one space has been the model that we're trying to that will be most successful in addressing the problems around Chemsex globally.
Thank you. Adding to that as well, I wonder if there's anything more you could say, partly perhaps about why it is that Chemsex has had such a strong association with HIV, and then also some of the good work that has been done mitigating harms which have been associated with chemsex.
Janey, do you want to do the clinical HIV stuff?
Yeah, I mean, I hope I'm not just I can't remember what the expression is, but teaching people to suck eggs or blow eggs. But essentially, when you think about chemsex and the kind of behaviours that it's really strongly associated with, they are all behaviours that are linked to HIV transmission. So having multiple partners with potentially very little kind of use of condoms, or if condoms are used, potentially not used correctly, and then you know, the duration of the chemsex events, which means that people may be having sex for a prolonged period of time, which then, you know, degrades the rectal mucosa and can increase the likelihood of infection. And so, yeah, so chemsex and HIV transmission are very, very strongly associated. I think there was a study from a sexual health clinic in London at St George's that showed retrospectively, looking back on case notes of men who had attended the sexual health service and reported chemsex use, that HIV incidence among those men that reported chemsex use was 5 times higher than among men that didn't report chemsex use. And so, yeah, so from the clinical side of things, you can really see how chemsex and HIV is just, you know, there is a huge potential for HIV transmission and STI in transmission and infection. And how that's being mitigated, or how we're, you know, there are services that are now, like David said at the beginning of the talk, where we, at the beginning of the chat, where we were talking about PrEP and PEP and people being able to access those. The problem is that sometimes, you know, if you are on a 5-day bender and you are, you know, really not engaged with anything other than your immediate, like taking more drugs or meeting more people, or, you know, moving on to the next thing, whether or not you're then able to take a hold of your, you know, telephone and realize that it's time to take your tablet of PrEP, or whether or not you even recognize that, you know, you haven't taken your PrEP, or you may not even know about PrEP, because PrEP is a relatively new phenomenon. I mean, I think we're very lucky, particularly in London and the bigger cities. There's been lots of campaigns around creating awareness of PrEP and trying to get people who are a higher risk of HIV infection onto quick access to PrEP. But there's been a huge, as I'm sure most people know, furore around access to PrEP and how it's been rolled out. And it's been rolled out pretty poorly and pretty slowly across the UK. Doing it as part of a study has probably meant that there are much bigger barriers to it for the general people that need it, rather than people who are already engaged with sexual health services. And so, yeah, we've got a lot of things in place that can help prevent HIV transmission and infection and STI transmission and infection. It's just really how services are able to engage with people, or how we publicize those things that, with the tools that we have in our armory, so that they're there for the people that need them the most. And I think certainly the last 5 years has seen a sort of pivotal change in terms of what we've got to offer, such as PrEP, because PrEP is a very easy tablet to take, and it, as David has said, it almost is very highly effective at preventing HIV infection. Yeah, it's just how people are accessing it, and whether we're getting, whether you know, the people that need it the most are accessing it. And there's lots of different resources that are trying to make it far more easy to access. Like, if you're not part of, you know, even before like a larger study was rolled out to recruit and offer PrEP to larger proportions of the population that needed it, there were activist websites that were springing up and were working alongside sexual health clinics to verify and signpost people to buy PrEP. And that's been going on for what, 2016, 2017, I guess, was I Want Prep Now, and Prepster started really kind of building a huge footfall of people through these websites and providing a service that really the NHS should have been providing but wasn't, and you know, helping people to get PrEP. But there is still definitely a gap in access to it.
Great, thank you. Anything to add on to that side of things, David?
Really simply put, gay men who engage in chemsex are the highest risk group for HIV acquisition and transmission in the developed world. That's just a plain old fact. So we got to, and they basically, given that, we want every single gay man or gay, bi, queer man that engage, including trans people, who is engaging in gay sex with chems, absolutely should be on PrEP. And they're not going to go to a drug service and have a PrEP assessment. That's just not part of the culture. Again, I think why it belongs in sexual health clinics. And why, if there's two men sitting in the waiting room of a drug service, okay, and one of them was a heterosexual, let's go stereotypes, okay, heterosexual heroin injector, street homeless because he's physically addicted to the drugs, so he needs money to buy his next fix and he can't hold down a job, so he's stealing from cars to do this. He's hepatitis C positive too. He might be sharing needles on the street, so transmission of hepatitis C. So in regard to that setting, he's ticking every high risk box on the assessment, every single one: transmission of hepatitis C, needle sharing, problematic addictive use, withdrawal and potential for overdose, and all these things. So he's going to be robustly engaged, and it will cost in England like thousands of pounds to keep this guy engaged in care. If it's a gay 20-year-old guy sitting next to him in the waiting room who's not using any physically addictive drugs like heroin, he's just using party drugs, and he's not injecting, just, you know, recreational. Having sex is not every day, it's just once a month or something. He owns his own home, he's got a boyfriend long-term, got a job, HIV negative, Hep C negative. He's not going to tick a lot of high-risk boxes there if he was there at all. They'll do their job in the drug service because they're good. They'll sort of give him some support, but he's not ticking the high-risk boxes. But if that same young gay man was in a sexual health clinic, he's going to have questions about the sex you had in the last 3 days, and you're a high-risk population. It could be, you could have caught HIV, so let's talk about HIV prevention, which that wouldn't happen in a drug service. PEP wouldn't be available in the drug service. The conversation about PrEP wouldn't happen in the drug service. Additionally, the cultural competency to talk about penises up bums with 20 people on Grindr and how do we talk about that, that's not going to happen in the drug service either. It will happen in the sexual health clinic. I can go on and on and on, but essentially the cost, if that guy becomes HIV positive, he will probably infect between 30 to 60 more people before he gets tested and engaged in treatment and becomes uninfectious. And so since it costs about £250,000 to keep a single person on HIV for the rest of medicines for the rest of their life, the consequence, the financial consequence of this guy being in a sexual health clinic where we can get him tested quickly for HIV, on treatment, and that can be millions of pounds if he's in the drug service is not addressed. The consequence of him not having that correct risk assessment can cost government millions of pounds just as a consequence. So yes, chemsex is an HIV issue. It's also a cultural issue. It's also a community issue. It's a sexual behavioural issue. And it's better addressed in places where all of those risk assessments and behavioural concerns are better addressed, which is sexual health clinics where gay men go by easily in floods of people.
And I think that's, again, kind of brings me on to saying something that I expect most people know, but I'm always surprised when there are people that don't, which is in the last 5 to 10 years, the change in treatment for HIV, and once somebody is diagnosed and on treatment, means that they are undetectable and then unable to transmit the virus, has such huge knock-on effects for onward transmission and actually eradicating HIV in terms of breaking this onward chain of transmission by potentially, you know, testing, and then getting the people that need treatment on, getting the people diagnosed onto treatment. And there's been, I'm sure you're aware of it, a huge global campaign, undetectable equals untransmittable. But what is important is getting tested to be diagnosed so that you can be undetectable and therefore untransmittable. And so again, that is where the sexual health services and integrated drug services are so important, because people who are going to drug services to get help with drug use may not be getting HIV tests there, or may not be offered HIV tests there, and their sexual health needs and their HIV needs aren't necessarily met there. And if you're then said, oh, well, you should go for a sexual health screen, go to this clinic over there, and you've already taken an hour out of your day to be at the drug service, you know, that's where the integration of clinics is so vital, because you're getting everything, you know, a one-stop shop under one roof. And really getting people engaged with testing, HIV testing on a regular basis, or recognizing that that is a risk, and if they're engaged in chemsex, that they should be testing on a regular basis, is also like a massive part of staying healthy, and then being able to manage an HIV diagnosis as if and when it arises.
If I can just add one thing. So if we're talking about a multidisciplinary team like drug services integrated with sexual health services to address chemsex, I'd also include a third discipline, which would be have the community organizations working as partnership with them too, so that the very community cultural issues around gay sex. And we're not talking about living life as a homosexual and societal homophobia. I'm talking about gay sex. So you need the community involved in that multidisciplinary team as well.
Great, thank you. So at this point, I'll say we've got, of our bullet points to get through, we've got one left, but that should also mean that if anyone's got anything they wish to ask about which we haven't talked about yet, please throw that into the chat and we can go on to more Q&A after the final bullet point. I also have a couple of questions I've been noting down I will bring to you as well. But so the final bullet point we had is chemsex and the future. So for that, what do you think is coming next? I don't know if this is just from, you know, you're having a keen ear to the scene, or perhaps from any of the longitudinal studies you discussed earlier, but where would you expect chemsex to move from now onwards?
I like to be hopeful. You know, I'm very aware that these drugs are not ecstasy and cocaine ecstasy. The chemsex drugs are really, they require a real skill set to manage them. So I think if this is ridiculous, but if gay men were taught in school about how gay sex can be a great pleasure and a normal part of life, and how to robustly dismiss the world's disgust of it and your own internalized disgust of it, and if you were taught at a young age how to set boundaries in regard to risky things and how to confidently go and get sex, and if gay men, rather than just thinking, I only go to a drug service when everything's gone wrong, but if they actually went to the drug services way before and helped establish those kind of boundaries, then I'd be hopeful about the future of chemsex. But at the moment, the support services are really just picking up the pieces, you know, applying plasters, so to speak. In regard to the future, a more grim version, if this was 1960 or 1970, and there were three people like us having a conversation about heroin, and one of us would have said, hey, there's a lot more heroin on the streets lately. Have you seen this? And there are a lot more presentations around heroin. It seems to be focused on people that have had very traumatic backgrounds, a lot of emotional difficulties and stuff. And it seems to be associated with poverty and crime. That's strange, isn't it? And one of the others might go, yes. Do you think this is just a passing trend? And one of us might have said, you know what, sometimes a drug comes along that absolutely perfectly ticks the boxes of a population that need it. And heroin kind of did that. And so one of us in the group might have said, well, I think heroin's going to be here to stay for a while. We might have to get used to our streets being populated by sort of street homeless heroin addicts. And that might have been a dismaying thing to say. So now there's three of us talking about the future of chemsex. And I think that chemsex drugs have come along at a complicated time, where HIV has made gay sex disgusting and about risk and danger and death. Society can think gay sex is disgusting. It's still changing, but a lot of our mums and dads do. And politicians and newspapers. And then there's Grindr and trying to adapt our sexual and pleasure and emotional and community needs in that kind of environment, which again needs a skill set. So I think at the moment we've got drugs that are ticking boxes that really work. You know, chems specifically are really good for the problems that gay men are having at this moment in history with gay sex. And I don't think it's a passing trend. I think that sometimes a drug comes along that just takes a hold in a community. And I think we're going to have to get used to the fact that our gay communities are not just dancing on ecstasy anymore. And there's going to be a lot more drug-induced psychosis, a lot of G deaths, a lot of people medicating their sex lives, a lot of people having trouble to have sober sex, form intimacies and relationships that are lasting and beyond the bubble of a 12-hour episode. I think in a dismaying way, we have to adapt and get our services ready and get our community dialogues happening to address that.
So
Janey?
if I can ask one quick follow-up. So yeah, we'll go to get Janey's take on that question. There's three now really good questions in the chat we'll move to, but one follow-up there, as you said, we have these chems which really fill a need within the gay sex community. So I may have got your word slightly wrong. And that's something that interested me. So you said the main chemsex drugs, crystal meth, methamphetamine, GBL, GHB. I think I got the acronyms correct there, and also to a lesser extent, mephedrone. And so mephedrone had its kind of time of popularity within party scenes in the UK, but the 2Gs and crystal meth are low prevalence drugs in the main hetero partying communities. So why it is they have not caught on in general hetero partying communities, and why they have caught on? Is it simply they fulfill a need, or is there some other perhaps cultural reasons that those particular drugs have arrived in the gay chemsex scene? And why do they stay as well?
In England, all of that was quite accurate. But if you look at Australia and Americas, crystal meth is widely used amongst heterosexual populations way more than heroin would be, and they are the main kind of drugs there. And interestingly, that the heterosexual presentation of a crystal meth user is a lot less sex-orientated than a gay man's presentation is. And so the answer to your question is so difficult to kind of give, but it's about availability of drugs, cost of drugs. It's about what purpose the drugs are fulfilling. If I'm going to have sex with Janey on heroin, it's not going to be a very horny experience. It's going to be a kind of loving experience, but we'll be lost in our own introverted kind of high and pleasure and peace. James, if we're going to have sex with you on ketamine, then it's going to be, it's not going to happen either. If I'm going to have sex with you on ecstasy, it's going to be a connected experience emotionally. I'm going to care about the things that you care about. And when we both realize we like the same music, it's going to be like boom, and the kissing will be phenomenal. I'll know how your skin feels like under my fingertips. It'll blow my mind. If I'm going to have sex with either of you on crystal meth, it's boom, 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 and it's fast and it's furious, and I'm insatiable, and I need the next thing, because that's just the nature of the dopamine, and I'm not very much in the present and the now. My ability to empathize is interfered with by a blocker, so my ability to filter what's appropriate and not is kind of way off, and it'll go on for days just because of the energy, and I'll never be able to be satisfied. It's the next thing, the next grinder shake, the next place to go to, the next porn to watch, the next sex act we can do, the next sex toys. And after the whole experience, I wouldn't be able to give you a single idea of what your skin felt like under my fingertips. So just drugs are very different with different experiences. Gay men live in a very sexualized world. All human beings need community. We've gathered around church steeples and campfires and villages, and we need community. Within those communities, there are hierarchical structures and social structures, and chimpanzees pink knits off each other for intimacy reasons. And gay communities, for whatever reason, for rhyme or reason, they've become very sexualized. It's a community of people that has been identified by sex kind of first. Men who have sex with men, not a man who has sex with men or men who love men. It's about men who have sex with men. And AIDS made our gayness very sexualized too. And so we live in a very sexualized thing, and there are structures and hierarchies within that. And the need to be successful and thrive within your community is true for all populations. And with the gay communities, certain gay communities, the need to be sexy and to have the skills to thrive on Grindr and to be hook up confident are very profoundly ingrained in survival and coping. And so a coping strategy for that would chems facilitate that. Ecstasy doesn't, but crystal meth does. So that might be some of the reasons why it's just taken off within those populations.
And with that as well, do cocaine and crack have a place in the chemsex scene? And I guess yeah, with that typology of drugs and sexual pleasure that you offered, do cocaine and crack fit into that, or are they largely shunned in the chemsex community?
Again, there's no exacts. It's interesting throughout our recorded history, the numbers of MSM, gay men who have used crack cocaine, is really low. It's really low, and it's never really been a part of the gay recreational sort of drug cultures. Interesting one exception though is as chemsex has developed, but a shortage of crystal meth in Rome has manifested, crack cocaine has taken up a very chemsex role within Rome, but that's kind of unique across the whole world. We're looking at that kind of with great fascination and trying to learn as much as we can. But crystal meth is starting now to fall into that, so the crack cocaine has started to dissipate a bit as well. Cocaine generally has always been a part of the recreational toolkit of gay men and parties, but it did drop off. It just doesn't compare to what crystal meth and methadone can deliver.
Cool. And I think in terms of prevalence of the individual drugs, it is, and again, this is from the data rather than from David's clinics, and I think this is fair to say that it is reflected in the clinic. That actually methadone and GHB are more popular and sort of the drugs that people tend to start off with, and it seems to be a smaller group of people that then use crystal meth. We certainly saw that around the most popular drugs to use were GHB, GBL and methadone. And it was actually only around 10% of people who were engaged with crystal meth, and that didn't drop off at all over a 3-year period. The crystal meth use basically stayed the same, whereas the decline in overall chemsex that we saw over 3 years was predominantly driven by a drop off in use of methadone, which was the highest, and was around 32% of people who were using chemsex drugs reported use of methadone, and then GHB, GBL, which was I think sort of a quarter, or around a quarter of people. And David, I think that's fair to say that that's reflected in kind of the people that you see in clinic on a day-to-day basis. Is crystal meth more? It seems to me, certainly sitting in front of somebody talking about drug use as a sexual health nurse, that there is a bit of a line that can be crossed when the people start using crystal meth, and actually lots of people are very happy to use GHB and methadone recreationally and as chemsex drugs, but I've heard unquantifiable number of times that no, I don't go as far as crystal meth. I don't cross that line. I've never done that. Yeah, that's it.
It's all about stigma. So the preferred combination would be crystal meth and G. If crystal meth wasn't so stigmatized and didn't have the huge consequences, I think people's preferred high would be a combination of crystal meth and G. But you can go to a party and do a line of methadone and do a shot of G, and it's entirely socially acceptable.
Exactly.
It's socially acceptable on the dance floor. It's socially acceptable on Grindr and on your profiles. You can even talk about it on Facebook, and at dinner parties it comes out afterwards. Crystal meth wouldn't. So even though I think they prefer to be in crystal meth, I think there's a huge stigma that you're the junkie if you do that drug, even though they prefer to be doing. So sometimes they don't disclose their crystal meth and talk about methadone instead, and sometimes some will just say, because of the stigma, I'm not going to go there.
And I think it is also true to say that like clearly David and I have both worked or are working in chemsex, and so therefore we actually have a huge focus on these drugs just being used for chemsex, but, and I see in the comments as well, there is a lot of use of methadone and GHB, GBL outside of chemsex use, but often, you know, the line of work that we're in means that we're just seeing it as chemsex drugs. And I mean, certainly people are partying and dancing on GHB, and, you know, I worked in A&E for a couple of years in the turn of, in around 2010, and I was seeing a lot of heterosexuals presenting with too much methadone use and overdosing on methadone, and it kind of went into the heterosexual kind of party world, and is now become far more popular and less so seemingly in heterosexuals. But yeah, there are crossovers of those drugs, but crystal meth I think has always far more been found to be used among the gay community.
Great, thank you. So I think now I'll try to move on to the questions, of which we've got 4 or 5 excellent ones of. So for each of them, I'll ask them to both whoever thinks they might have an insight. So I'll start off with Andy saying, what do you think law enforcement could do better in tackling this issue in the future and deal with this matter in a way that helps? And I'm also interested in my own follow-up to Andy's question is, in your roles, did you ever need to speak with law enforcement, or was there ever a firm separation between your work and law enforcement, and were there times it kind of needed to be connected? So Janey or David?
I have to say, in terms of sitting in front of somebody as a sexual health nurse and having somebody talk to me about their sexual behaviour and their drug taking as part of that sexual behaviour, only in terms of where their consent may have been compromised for having somebody having sex with them that they may not have consented to, and the issues around consent and how you navigate that in chemsex are absolutely huge, and it's such a difficult path to navigate. And I think, like both of us, David has, will have a lot to say on that as well. But certainly in terms of being an advocate and caring for the person who's sitting in front of me, no, I haven't needed to get to speak to law enforcement or to use law enforcement. I think there is a huge problem with how things are reported and how law enforcement actually then takes on or navigates this issue around consent. And I think there's a lot of mistrust and an inability to report things that have happened during chemsex parties because of this worry about how the law will come down on the use of drugs within that setting, rather than whether or not somebody was raped or had gross sexual assault occurred. David, is that I think we're probably on similar pages there.
My impulsive reaction to James's question is I wish law enforcement could just fuck off and leave it alone and leave it to healthcare, because drug use and the consequences are almost exclusively a healthcare issue. Janey and I have people sitting around us who have broken the law because they've done drugs, because they bought drugs, because they are in possession of drugs, because they deal drugs, and none of that is a reason for us to call law enforcement. Obviously, there's a role to play, because there are sexual assaults and there are crimes and there is violence that kind of happens, particularly in association with crystal meth, where we need to do things, and particularly in regard to consent and things like this. But in my engagement with law enforcement, it's a real challenge, and one of the challenges is not so much their fault, and that part of it is the sort of a stereotyping of gay men, and a hard difficult challenge for a heterosexual police man to get his head around a gay man who chooses to have sex with 10 people and take huge risks and dangers and do that every weekend, and just crime. They just see it, crime all over it, whereas actually there's hardly any of it's got anything to do with crime at all. But a lot of the problem too is as chemsex becomes more problematic in a city like London, I can't talk enough about drug-induced psychosis. A very typical presentation, I don't know how much of this you see, Janey, is when you've been awake for 3 days and you've done crystal meth or methadone, a very common symptom is that you have perceptions of persecution. And it's like there are cameras everywhere, or I feel there's people knocking at my door, and sometimes there's visual hallucinations, but more often it's just perceptions of being persecuted. They want to do me harm. They assaulted me. They intentionally gave me a disease. They put strange things in the drugs. These are very normal parts of a person's chemsex experience that we don't talk about much. They don't talk about much, except in crisis. And so when those stories that aren't being able to put through a filter of a kind relationship, let's unpick what really happened from the perceptions and the potential for psychosis. But when some of that stuff reaches the police, they want to get involved now. They want to jump on Grindr and stop it happening, and they want to stop all this chemsex danger stuff right now. And I find it really challenging to incorporate police in these conversations where it's needed, and figuring out myself where it's needed when a person is sitting in front of me saying he got sexually assaulted, which he says every single time, once a month after every chemsex episode, but a week afterwards says, oh yeah, no, I do. That is a fantasy that keeps happening. It's in my paranoia and persecutions. And it's really complicated, very, very complicated part of my job.
And I think there are really, it's very difficult for men, because there are lots of incidences, and I can think of a few men who've sat in front of me and said they don't know who they've had sex with or whether or not they consented to it, and in fact they don't think they did because they can't remember anything about it. So how could they consent to having had sex that they couldn't, they can't remember to, and actually, they if they were to go to report that crime as a crime of having been raped or sexually assaulted, it's very difficult for them to feel like they're going to be taken seriously, because they are going to have to admit to having had drugs, or maybe even unintentionally taken drugs, or maybe intentionally taken drugs. But I know this is a little bit of a different way of looking. But I recently watched, I don't know if anyone saw on BBC, I May Destroy You, and I thought it was really striking how there's these two characters. It was a brilliant series. A lady who was potentially, was date raped and reported it to the police, and the difference in the way that was carried forward by the police and by their follow-up with her, and then her best gay friend, her best friend who was a gay man, who also then went to report a rape where he had intentionally met up with somebody but not permitted to have condomless sex with this guy who lay him on the bed and anally raped him. And the two ways that this was dealt with in this TV drama were just absolutely, like, it just made me think again, how hard it is for men to report stuff happening to them. And actually, our law enforcement, we need to, there needs to be kind of more of a conversation between sexual health services, drug services, law enforcement, about how we can build an environment where people actually feel like they could, as a gay man, have faith in or confidence in a service that isn't then going to make them face the consequences of having taken drugs rather than having been anally raped. Sorry, that was I only recently finished watching it, and I thought it was really interesting.
So yeah, thank you for that. I actually had a kind of half-prepared question about chemsex and consent. So I'm very glad that the conversation had gone. Then I'm actually going to ask, what is your solution to that? Well, I guess you suggest, a connection of, community, sexual health, law enforcement would be ideal, but I just recognise the difficulties in, certainly when I was working in the needle exchange, the police knew to give a wide berth to that area, since of course service users needed to know that they weren't going to be arrested outside. So it's going to be very difficult to have law enforcement involved when needed to, but all service users feeling the freedom to come in and be open without a fear of involuntary law enforcement activity. I guess anything where there is illegal drugs, it gets very difficult then when you need to be in a service that's non-judgmental and open doors. It's difficult. Unless, I don't know, either of you have anything more on that topic?
Well, yes, it is a really a community discussion first, I think, because the role of consent in a sexualized community is really difficult. Anyway, if I'm walking through a nightclub with my shirt off, does that mean someone can tweak my nipple or not? And that's simple. That's for me to decide. It's really quite simple, but every gay man around us answers that differently. And if I'm walking through a sauna, does that mean that I'm sexually available to everyone, or is everything comes down to a negotiable thing? And of course, if you're really high but competent, and who makes that decision, but you feel competent at the time and you appear to be competent and you invite someone to have sex with you. But then 2 days later, when you're putting together the pieces of all these traumatic things that happened to you, and it's hard to take ownership over what you did, and you think I wasn't really consenting there, and that person assaulted me. But a conversation with that other person that is the perpetrator of the assault might be completely baffled, because to him it looked like verbal consent, physical, behavioral consent. It's a really complicated issue to talk about that can't be put down into boxes. And it's really, the only solution is every human being have the ability to know what they're worth, and know when something feels uncomfortable, how to say it out loud, how to communicate your own boundaries in any given moment, even when something takes you by surprise, and to be able to say, I'm uncomfortable with that, and enforce that in a kind way so it's understood in whatever environment you're in. These conversations aren't happening. They should be happening in school. They should be happening from the age of 6 onwards, about how to say something feels uncomfortable and what's the sentence you say when something feels uncomfortable. That should be happening in school at a very young age. And because it's not, we've got a global full population of people who don't understand consent, how to communicate it, or even what it means to them, let alone how to put it into context days afterward.
Cool. Great. Thank you very much. I'll move on to the next question. I've noticed that suddenly we might be running out of time. So a question from Ben. Would it be possible to have a health or harm reduction workers within the Chemsex parties or communities themselves?
Yes, and there are all over the world, brilliant examples of them. I've got a brilliant colleague in Canada who goes out and delivers dildos on demand on Grindr. And while he's there, he provides all the harm reduction information and stuff you need. There's so many examples of that around the world. There's an outreach worker on Grindr right now, working here in the UK, that sort of reaches out to people to see if they're experiencing psychosis or anything that he can help with. It's happening and it's brilliant.
Right. Thank you. From Emma, where are Chemsex parties being organised? Is it on Grindr? How do we be proactive in speaking to those people on Grindr, and how can we access them? Netreach on Grindr only allows sexual health profile at the moment. Therefore, we reply to the users who approach us.
I think approaching people on the platforms where it's welcome is important, and I think it would be good for it to be available there, but I do think that gay men or whoever uses Grindr wants to protect it for the purposes they want it to be. I know that some people don't want their fantasies adulterated. We know that from pornography. I've got a great, my best friend is a sex worker in porn, and he came out as HIV positive and became a very loud HIV activist. And the minute he did that, he lost more than half of his fans, because they didn't want to, it interfered, it adulterated their fantasy of him. Grindr's a bit that way too. It's a very fantastic place. And so it's about, but nonetheless, there is, like I said, my another good friend is actually outreaching on Grindr right now, not as an organization, but his profile is, I think it's just a medical kit picture or something. Mm-hmm. Remember other things too, like, you have to reach people when they're ready to be reflective. Sometimes when people are doing drugs, if someone's invading their space when they want to do drugs or they're high, they see that as an invasion, and you're ruining the relationship that might be important later when they're sober. So it's, you want to engage people when they're ready and in the place when they're ready. You don't want to you don't want to force it down their throats either. So it's very nuanced. There's no perfect solution. Respecting spaces. You know, as a white man, I'm not going to invade a black person's space, and as a health organization, you don't want to invade Grindr too, unless it's done in a very culturally competent and welcome way. And I don't know what that is. It changes per user. So it's a
and I think a part of the responsibility of sexual health services and like integrated drug services with sexual health services is to provide that, not necessarily to like David said, invade Grindr as a space, but to provide the opportunity for people to have an open conversation with somebody, to plan their sexual behavior and to plan their chemsex so that they can manage it safely, so that it isn't necessarily a harmful behavior for them, and so that they know what services there are and what they can do to actively engage in the kind of sex that they want with the people that they want in the manner that they want, as safely as possible. And I think that's where kind of trying to be a support system rather than trying to be an actual kind of do this or don't do this or face these consequences is the difference in a good service, and one that is kind of sort of fighting against the community or group of people they're trying to work with.
Great, thank you very much. Moving to the next question from Massimiliano, who says, in the main cities in Italy, gay and bi guys have started using GHB not only for sex, but for dancing instead of taking ecstasy. They are taking GHB to dance at clubs. And I was reported their straight friends also take GHB as well for clubbing. Do we have evidence of this in any other countries?
Yeah, as Janey mentioned before, there are probably more people using G for dancing and clubbing than there are for sex. Again, something which hugely is confused in research. Some people just research, wow, gay men doing that much GHB, but more than half of them are just dancing with it. So yeah, it began as a dance drug and it morphed into a sex drug. Spot on, Massimo. I know he was responding to something we were talking about earlier. And hi, Massimo.
Right, thank you. Next from Jason Bates. And so I can only speak from my experience in the SU work with who report once they are on Grindr, etc. The decision has been made to engage in chemsex and they focus on that. So we need to find a way to reach them before they log on to the app, not to dictate to them, but to give the info to help them make more informed choices. So that's, yeah, so I guess my follow-up to that question as well is, so yeah, it seems there's outreach through Grindr. It seems help is offered when people visit sexual health clinics. Are there other means of outreach or other places where gay men seek help for these sorts of issues?
Yes, Janey touched on this before too. I think that I wish that the things that lead to problematic chemsex are the fact that we're not talk about that gay sex is not celebrated as a thing in sex education in school or in a family unit at home when we're growing up and around our teens. The fact that drugs are considered shame, the fact that they are more considered responded to in a criminal issue more than a healthcare issue. So all of these things, if we did the work earlier in very broad sex positive, LGBT inclusive sex education in schools and in our communities, I know that if I was supported to know that gay sex is more than just hooking up, it's more than just disease, it's more than just HIV, it's more than just risk, it's more than just sexual health clinics, it's more than just a one-night stand. It's also something that gay sex is something that I might have with my boyfriend in the morning before he goes to work, even though I'm not in the mood and my breath stinks and his breath stinks, but I do it because he had an awful day yesterday and the purpose of sex is to make him have a brilliant day today. So all of if I'd been introduced to sex as all of its possibilities and roles in my life and the way it can fit into a life and not just perhaps be the only recreation available to me in my community. If there was a broader conversation about gay sex and about drugs that were socially acceptable, and if people considered a chemsex support service as not the place you go when everything's fallen apart, but a place if you're going to go parachuting, you don't just go buy a parachute and jump out of a plane. You learn how to do it first. That's like common sense. If you're going to use some of the most dangerous drugs on the planet, you learn how to do it first. For me, that's logic. And all of my work around the world is supporting chemsex services to be that place, not the place you go when everything goes wrong. By that time, you just need an addiction service. But, chemsex support services are about how to skill yourself up to manage your sex life and your hedonism and your joy and your pleasure and fit it into the structure of your life and to set boundaries and to be safe.
And definitely that conversation needs to happen a lot earlier in life in terms of, preparing somebody for, I think, coming specifically speaking from a London sexual health clinic, young men turning up in London, which has got a huge scene and like lots of different kind of levels of intensity, and really being confident in yourself and who you are and how to navigate that, like David said, requires a huge skill set. Particularly if you're coming from you know, a more less cosmopolitan place, and being faced with all these decisions on how to, you know, make friends, you know, meet people, take drugs, use like the social media apps and social networking apps and stuff. And I think that actually we have sort of the acceleration of technology and drug use and the kind of changing cultural scene, which is so like evolving all the time, giving good and open and honest sexual education at school, and allowing people to have access or encouraging access to like more sort of educational tools to equip you with how you would safely negotiate sex or take, you know, or take drugs without it being this massive taboo subject, would mean that yeah, I think it's like my biggest thing is more around like education in schools, and how we can have honest and open conversations with children, you know, like, you know, with people on the cusp of like understanding their sexuality and adolescence, and, you know, all these like difficult things that happen, and we think, oh, they're, you know, too young, we don't need to talk about that yet. And actually we do, and we need to talk about it really well and really openly and really honestly, and that is then going to give somebody a life tool to be able to negotiate a change in, you know, scene, or like, you know, the challenges that come at them. But we don't have that really. I still feel like sex education in school leaves a lot to be desired.
Yeah, and actually I'll read a comment from Ben earlier relating to that. He said, working with vulnerable young homeless people in London, the risk factors that chemsex poses to young gay men are high, but engaging in chemsex for several reasons will always be attractive for some. Issues of consent and capacity often raises concerns, as David was saying earlier, especially if they are under 18, and I hope they were able to have more conversations and education on these topics with the younger generations, as David had said we had in Amsterdam. I actually have one more comment I will read also. This is relating to our discussion on law enforcement and policing about 10 minutes ago. Wayne saying, modern day policing is changing daily. The safeguarding of individuals is paramount these days, and policing it has its part to play in ensuring the well-being of people. Gone are the days of just catching and convict, but it appears that policing still carries that stigma. Partnership working is a big part of policing in these modern times. Perhaps the public are unaware due to poor media coverage. And yeah, it certainly seemed from discussion earlier that more partnership, which can be done in a way, as I said, it's difficult with the illegal status of drugs. People will always be difficult to report drug-related activities to the police, but it does seem like partnership working in the future certainly be a way to go, especially if that can be navigated. So that's all the actual questions gone through. I don't know, David, Janey, there's any other topics you wish to move through? Don't know if anyone else wants to chuck a question in quickly before we go.
The comments are brilliant. I think we've covered just about everything. I'm happy to stay longer if there's any more questions. Janey?
Yeah, I think when we were thinking about chemsex in the future, I think one of the things that really struck me was the position that we're in kind of coming out of lockdown, which is sort of more the present rather than the future, but just really with Dean Street doing 56 Dean Street, the sexual health clinic, doing really great work and reaching out to like other sexual health clinics in European cities and across the world, to really see lockdown as an opportunity to help prevent or to break this chain of transmission of HIV. And I mean, this is like encompassing chemsex as well, and trying to, you know, seize an opportunity to actually get people tested and to act appropriately and get people on treatment if a test is positive, because, you know, lockdown has potentially really seen a potential decrease in the number of hookups and the number of people kind of having like casual weekend sex, and the potential to then get tested and get more people tested and diagnosed and on treatment if necessary is really huge. So I think that's that's something that I've certainly been kind of in the back of my mind these last kind of couple of months, whilst that COVID has been, you know, running its course, well, not running its course, but yeah.
COVID has been an amazing time of making us sit down and reflect on the role sex plays in my life, the role recreation plays in my life, the role friends and connections play in my life. It's been a real time of reflection. So from my experience, a lot of people have found it a helpful, reflective time to look at the role chems and sex and hooking up can play in their life. And I'm glad to be a part of those conversations.
Great, thank you very much. I see there's no more questions in the chat, so I think this is a good question to finish. So thank you so much, Janey and Dave. It's been absolutely wonderful. Yeah, hugely informative for me. I'm sure hugely informative for our guests as well. Thank you everyone who joined as well, and apologies for any difficulties you had logging in. That was 100% my fault for incompetence of pasting a wrong link into certain places. You'll get one more email from me on this subject, which will be a YouTube link once, I'll agree with David and Janey, they're okay for this to be YouTubeized, and then it can be a great resource for us to look at again, use educationally, etc. So yeah, thank you. Has been wonderful. Thank you all for joining. We were initially aiming to do these every 2 weeks. I think that's just a bit much, especially since over here in Singapore it's between 7 and 9 p.m. and that's taking out half of my Friday evenings. But we'll say that we've got our lockdown rules are currently all bars need to shut at 10:30, so I might quickly sprint out of the house once we're done to try and see if I can get a last order or two to cool down from all of this. But what I was getting to is we hope to have more deep dives on drugs in the future. Unfortunately, we had 2 excellent topics for September, and none of our excellent speakers can do any of the less excellent dates that we proposed to them. But we will keep in touch with all of you on the various social media channels. I'll probably might even time posting out the YouTube link when we've got a solid date of the next one to invite you all to. So once again, thank you very much all for joining, and very much hope to see you all again. Next time I'm in the right continent, I'll try and get you two for a pint. Would be great to meet you, and yeah, would be great to meet any of you in the future too, and also to have you over for more of the deep dives here on Zoom again. So all the best, have a good Friday, good weekend, all of you.
Bye everybody, thank you.
Bye.
Bye.